So I was invited from the onset to be involved in the FEMaLe project. So I attended the submission of the project for the grant Horizon 2020, and I found it as an excellent idea because it gathers a lot of experts in endometriosis, which work in very different fields of endometriosis, and put them together around the same table in order to discuss and to find solutions, improving the awareness and the diagnosis and the management of endometriosis. So I had no hesitation to answer affirmatively to this very nice project, which was awarded by the reviewers. I think, honestly, I think I had two professional strengths. The first one is the surgical experience, because I started the surgery of endometriosis 18 years ago. And more than 10 years ago, I decided to focus exclusively on deep endometriosis, meaning that today I have an experience of more than 1,500 surgeries of colorectal endometriosis and 150 sacral plexus endometriosis, more than 80 diaphragmatic endometriosis, and so on. And the second strength is my PhD certification, which is in epidemiology, and this helps me to decide to build a prospective database as early as 2009, meaning that now I have a database including more than 7,000 patients with endometriosis, with a very detailed preoperative assessment, very detailed surgical notes, and routine follow-up carried out by dedicated clinical researchers. And this database helps me to routinely publish observational studies in endometriosis, and this is my, I think this is my strength, because skilled surgeon we have in every country, but such databases are very rare. There are a lot of surgeons who perform a lot of surgeries, but when they come back to the medical notes and they want to publish a study, retrospective study, there are a lot of missing data, which renders very difficult to draw a conclusion. This never happens to me. So for me, being a FEMaLe project advisor is first of all an honor, and secondly a pleasure, because it is a pleasure to be in the same boat, in the same team with people such Horace Roman or Krina or Andrew and many others, and I am more involved in a specific field of this project, which is the development of artificial intelligence, meaning that my skill and my surgical videos may be used to try to develop the computer which enable to recognize anatomical structures, the blood, the ureters, the nerves, and to help to step ahead and to try to introduce more artificial intelligence in endometriosis surgery. And this is a very, very long way, because we were just the first step with the augmented reality. But I think that in the future, as we could progress with the autonomous cars, we are able in the future to progress with autonomous, more or less autonomous surgeons, with computers which can gather the experience of thousands of experienced surgeons, and maybe be able to do better than each one of them. So to date, I think that my strengths have not greatly been used for the FEMaLe project, but I think it will happen in the next future, meaning that I will be asked to provide videos with surgical steps to be introduced in the computer, and then to review the computer data. So I think I'm able to provide, my strength is that I'm able to provide steps in rare localizations such as sacral plexus, sciatic nerve. So meaning in these surgeries which are concentrated in very expert centers. So I think it will happen in the next future, because the field of the artificial intelligence is to be done in the next future. There is a second field where I may be useful. I know that the teams involved in genetics are working to try to define profiles of patients more likely to present some subtypes of endometriosis, because until today the basic research, in my opinion, has not focused on subtypes of endometriosis, because endometriosis is something very, very large and very heterogeneous. And I think that in the next future, they will try to focus on very small populations of women with homogeneous disease, let's say patients with only ovarian endometriosis, patients with deep endometriosis of the parametrium. And in this case, to recruit the population of this woman, I think that the centers with high volume of surgery are very useful, because they are able to recruit in a short period of time a lot of patients with very homogeneous presentation of the disease. So I can be useful to provide samples, specimens, or blood samples from a very, very homogeneous population of women. Until today, I saw that they were looking for genetic profile in endometriosis, but endometriosis, or in stage 2 endometriosis, but stage 2 endometriosis is very, very heterogeneous. Stage 4 endometriosis is very heterogeneous.
Yeah.
So I think that more focused studies are required, but the more you focus on a specific localization, more is difficult to have a big population, because of course you will reduce the field of the recruitment. And for this reason, high volume facilities such our institute is very useful to recruit in a short period of time women with a very, very homogeneous subtype of the disease. But for example, if you want to look at the genetic profile of women with sciatic nerve endometriosis, this is a very, very rare localization. So if you involve 3 or 10 centers where one case is managed every 2 years, of course, you cannot go far. But if you involve a center as ours, where 10 or 15 women are managed every year, you may have shortly, you may have, in a short term, you have the sample which may allow to draw conclusions. Our patients with endometriosis are already and or eager to participate, to be involved in studies, because all of them said we have to move forward, we have to improve the research. They all of them answer our questionnaires in the database, pre-operative, post-operative questionnaires. So they are ready to give from their time, to give blood samples or. But I think that the recruitment should be based on high volume facilities, because in this case, in a short time, you have the sample you need to make the study. And honestly, our institute is continuously, every week, we are asked to be involved in 1 or 2 or 3 studies. So usually we accept 25% of them, which are the most interesting. But we are involved in the EndoDiag study. We are involved in the salivary test study. So we are involved in everything happens in France in endometriosis. So we wish to help the FEMaLe project in the same way. We are citizens of the 21st century. So for us, for me, for my colleagues, the gender equality is a fact. I have 3 daughters. My team involves more women than men. And we decided to look for the skill, for the competency, without making distinction between genders. And I think it is logical that it happens like this. So of course, we support all the projects which promote the gender equality, and we apply this principle in our daily practice. The diagnostic delay worldwide seems varying between 7 and 10 years. This is the delay between the first symptom, which usually is dysmenorrhea, severe dysmenorrhea, and the diagnosis of endometriosis. I think that this delay may greatly be shortened, but of course, daily practice, we cannot shorten it too much, because the dysmenorrhea is a non-specific symptom, meaning that there are much more numerous women with dysmenorrhea without endometriosis than women with endometriosis and dysmenorrhea. Furthermore, dysmenorrhea occurs in adolescents, where the imaging examinations are usually negative. So we face with the difficulties to assess the diagnosis of endometriosis in adolescents, because we try not to perform the surgery too early. The MRI and ultrasound usually are normal or negative. So we have a real difficulty to assess the diagnosis of endometriosis in a woman under 20. That's why I think it is difficult to shorten this delay, except if we find salivary or blood test, very sensitive and very specific, able to state that this young woman has an endometriosis without having a look into the abdomen through a laparoscopy. And it seems that the recent data about the salivary test are very promising, and I think this diagnosis delay may be shortened very soon, thanks to this test, salivary or blood test. Now I just want to emphasize that there is another delay, which is very important, is the delay from the diagnosis to the accurate treatment. And this delay frequently is longer than the delay to diagnose, because in my daily practice, I perform very complex surgeries in women, which diagnosis has been known for years and years. However, they come to the surgery many years after with very, very severe disease. That's why the awareness should focus not only on the diagnosis, but also on the accurate management, early accurate management. I think it's much more important, because for many women,
yeah,
the day of the diagnosis is the onset of a very, very complicated way, and some of them even regret to have the diagnosis, because from this moment the pills are given, hormonal treatment, they feel worse, they have weight gain, and then they arrive several years to the surgery, and after the surgery they feel better. And this delay between the diagnosis to the surgery for them is too long. It may take 20 years, you know. And this delay can be shortened because it requires simply to teach to physicians that endometriosis is not necessarily pill and hormonal treatment for any prices. And also we have to fight against some fake news, such as if you have a surgery, you will be infertile, you're too young to have a surgery. So there are some fake news which increase the diagnosis up to the right treatment. And here we can immediately do something. I think the first time when I said myself that FEMaLe project is a success, it happened 4 months ago in Edinburgh during the World Endometriosis Congress, where during one day we had a session around the FEMaLe project, and the conference room was full of people involved in the FEMaLe project, and I was happy to see a lot of colleagues, a lot of friends and experts, and each one had the time to present his thoughts, his projects, and I said, yes, together we are on the right way. And anyway, gathering all these people together is a success. So at that time I said, yes, I understand now what FEMaLe project means, and I'm sure we'll go very far together. So I told you that I'm involved in the development of artificial intelligence and identifying subtypes of endometriosis, but I'm not sure that the game will be for me. I think it will be more for young surgeons who have a long career ahead, because the introduction of the artificial intelligence will take some time, and there is a risk that I will be retired or just 2 or 3 years before being retired when this will come in the daily practice. So for me, the major gain is the pleasure to work with so valuable experts, and this is honestly for me is very profitable to share with them, to be a part of this team, and to participate to all these projects of brainstorming, and to be inside. This is the first gain for me. And I think FEMaLe project benefits concern young women, adolescents, my daughters who are very, very young and who may be at risk to develop an endometriosis. So I think that they will benefit from the FEMaLe project results, not me. The benefit you have yourself is that to be there at the good moment, at the right moment, and to do the right thing, not
Yes.
for you, but for next generations. So I think that for me, the biggest problem with endometriosis is that we do not know where the endometriosis cells come from, and we have not treatment, a therapy, which focuses specifically on the cells, on the disease. Today, with our medical therapy, we simply try to stop the periods and to freeze the disease as is, to stop the development, and to try to avoid recurrences. However, the hormonal treatment you use are contraceptive and cannot be given to women who intend to be pregnant. So the problem is that we do not have a treatment which is specific, works on the endometriosis without being contraceptive. And for these reasons, we cannot avoid the development then towards very severe forms, which requires very complicated surgeries. So honestly, I think that in the future, I'm sure that now the prevalence of endometriosis is increasing for numerous reasons related to our lifestyle, to the pollution, to many reasons. But I am also sure that the prevalence will decrease in the future, maybe before the end of the century, because our colleagues working in basic science will finish by identify some receptors which are presented on by the cells of endometriosis, and they will identify a therapy related to this target, and like this, the disease could be controlled since the adolescence, and the surgeries, as we are doing now, will progressively disappear. So I think our biggest problem is that we do not have a specific treatment. We do not have a good knowledge about where this disease comes from. But in the future, if I had been political, but it will never happen, I would have focused on the help on basic science to try to develop this research towards a receptor on the endometriosis cells and a therapy directly focusing on this target. And I think that in this way we can efficiently fight against the endometriosis. And I am sure that will happen in the future, maybe before the end of the century. So me, I am a surgeon. I am helpful for the patients suffering from endometriosis, for sure. But the solution, the definitive solution to fight and to win, to defeat the disease does not come from surgeons, but from basic scientists. And I am sure that we'll be able to find a way to definitively control this disease, which may become a very, very big health problem in the next future. Before the end of the century, for sure. I'm for sure that once we define the subtypes, we will be able to control them by identifying targets and then providing treatments which are not hormonal, so which are not contraceptive, which may be taken in the long run without major side effects. And in this way, the very severe forms of the disease will progressively disappear, and surgeons like me will belong to the history. If I had been political, I would have support the basic research in endometriosis, and promote these teams looking for searching targets on the endometriosis cells, which allows ultimately to find a treatment, a more specific treatment against endometriosis. So I think that the basic science is the solution to defeat this disease, not the surgery. The surgery helps most severe, most severe forms of endometriosis, but the surgery is not the solution, even though numerous surgeons think that the surgery can cure the disease. I think that the basic science is the solution, and I think that if a researcher such as Krina will finish by find a treatment efficient against endometriosis which is not hormonal, I think it can be awarded by a Nobel Prize, because it will find a solution for so many young women suffering more or less because of endometriosis.